that, I'm going to kick things over to Jonathan to actually begin some of the overview of many of the critical elements that we'll be talking about as we go through the case studies. So, Jonathan, do you want to start with the small group considerations?
Sure, thanks, Ted. The next couple minutes we'll talk a little bit about the considerations that small employers have, and just in order to frame that, please keep in mind that small employers are those considered with fewer than 50 full-time employee equivalents. So, a couple things that small employers really need to be aware of, and this is probably stuff that you may have heard in the past, but there will be plan design limitations, and the plan design limitations will be surrounding or determined based on actuarial value. And the actuarial value is typically referred to as or grouped based on these metal tiers. So you will talk about in a little bit more detail later what those metal tiers are, but they're the bronze, silver, gold, and platinum metal tiers that you've probably seen in the past. And we'll get into a little bit more detail later. So another one of the considerations that small employers are going to have is the maximum deductibles on fully insured plans. So beginning in 2014, small employer fully insured plans will have a maximum deductible of $2,000 for a single and $4,000 for a family. Furthermore, in terms of plan design, small employers are going to need to implement an out-of-pocket maximum of $6,350 for a single, $12,700 for a family. Now, this is a little bit unique in that this is a true out-of-pocket max, where many employers are used to seeing out-of-pocket maximums maybe only applying to deductibles and coinsurance. But in the future, all out-of-pocket expenses borne by an employee must accrue towards the out-of-pocket maximum. So it's a slight variation in how plans are designed and operated than today.
And just a couple of quick comments on that. So it does suggest that in this marketplace, employers will be looking at some types of plan design changes to comply on that true out-of-pocket.
Right.
And then the other thing is there any kind of a maximum deductible limitation for self-insured cases?
No. So the self-insured market will not be required to comply with those deductible limits or maximums.
But they will for the out-of-pocket maximum.
Correct. But yes, correct. For the out-of-pocket maximums, they will need to comply. Right.
Great. Thanks.
So moving on, there's some more small considerations for small employers. Namely the rating limitations. And this gets a little bit more into the weeds here, but small employers will be subjected to adjusted community rating with their insurance carriers. And really what that means is that the insurance carriers will have new rating requirements they must follow that could impact the premium rates for employers. The first one would be the age adjustment. So from top to bottom, the rating range can only be 3 to 1 based on the age of the group. Also, there can be a 1.5 to 1 relationship or price differential for tobacco use, and then there will also be rating adjustments for enrollment type and geography. The other issue is the fact that the small group market, at least on a fully insured basis, will be guaranteed issue and renewable. And really what this means is that in the past, for smaller employers, they may have had to go through an individual underwriting process. While that will go by the wayside, there will likely be an impact to cost. And not to scare anybody too much, but we've seen numbers between 30% and 300%. Now, for most of our audience, it will probably end up being closer to the 30%. We've seen some of the higher numbers in southern states like Texas. So if you do have operations down south, you may find that the rating impact is different based on geography.
Just a couple of questions have come up as we've started right away, and I'd like to clarify those. So first off, definition of a small group for our purposes today is less than 50 full-time and full-time equivalent employees. So that's what we're talking about in the small group area. There's been a couple of questions about out-of-pocket, and I think as Jonathan mentioned, we're talking about true out-of-pocket costs. So it includes things like co-pays, meaning doctor's office visit co-pays, prescription drug deductibles, overall deductibles in your plan, your co-insurance. All of that rolls to the out-of-pocket limits that you addressed earlier. What is not included in there was there was a question out there talking about are employee contributions included in the out-of-pocket? And the answer there is no, they are not. Employee contributions are premium sharing. So when we're talking about true out-of-pocket costs, we're talking about the out-of-pocket cost an individual pays relative to the plan design features itself, not the cost sharing to participate. So hopefully that helps out from an overall standpoint as we move through the rest of the presentation.
All right, I'm going to turn things over to Scott. He's going to talk about some of the large group considerations.
Yeah, and I'm going to try to get through this relatively quick and really just more of an overview as it relates to the biggest reform item that's impacting large employer groups effective January 1st, and that is the play or pay mandate. And for those of you that joined our last webinar last month, you can certainly go back to our website and pull that up. And there we discussed in a lot more detail the play or pay mandate. So there's that additional resource if you want to go back and get more detail. But at a 30,000-foot view, the pay or play mandate, really we're going to consider a couple things. So first of all, the play or pay mandate only applies to a large employer. Again, that's by definition an employer with 50 or more full-time and full-time equivalent employees. So those employers are now required, effective January 1st, to offer their full-time employees, and they only have to offer coverage to their full-time employees. They have to offer coverage that meets certain requirements, or they are potentially subject to a penalty. So a couple things. A full-time employee now is defined as somebody working 30 or more hours in a week, or the equivalent would be 130 hours in a month. Okay? If an employer does not offer coverage, if a large employer does not offer coverage to its full-time employees and their dependents, and from a reform perspective, dependents only adult children, you do not need to include spouses. But if an employer does not offer, a large employer does not offer coverage to its at least 95% of its full-time employees, then effectively they are subject to the no offer penalty, which mathematically is $2,000 per full-time employee minus the first 30 employees, contingent on the fact that they have at least one employee purchase subsidized coverage through the public exchange. Okay, so that's the first penalty, the no offer penalty for an employer that does not offer coverage to 95% of their full-time employees. The next thing to consider, even if a large employer does offer coverage, if the coverage it offers at least 95% of its full-time employees doesn't meet a couple criteria, the first being minimum value. And effectively, minimum value is when you consider the total expenses that a plan is subject to, if the plan considers or pays for at least 60%, therefore, by definition, the employee is paying the remaining 40% by way of deductibles, co-insurance, co-pays. As long as that 60% minimum threshold's been met, that requirement has been satisfied. From an affordability perspective, we're simply looking at what does the employer charge for single coverage relative to the employee's household income. There are a couple safe harbor affordability provisions that were released in most recent guidance. I'm not going to get into the detail in this webinar, but as long as the employer does not charge more than 9.5% of an employee's household income, the plan is deemed affordable, and the employer is not subject to penalty as long as the plan, again, meets minimum value and is affordable. If one of those conditions is not met, it's either doesn't meet minimum value or it's not affordable, the employer is subject to a potential penalty. The penalty is the lesser of, $2,000 per full-time employee minus the first 30 employees, or $3,000 per employee that purchases subsidized coverage through the exchange. Okay, and again, that's all predicated on at least one person purchasing coverage through subsidized coverage through the exchange. Okay, so moving on. The next thing real quick, individuals making less than, or up to, 400% of the federal poverty limit, they will qualify for some type of government subsidy when purchasing coverage through a public exchange, as long as their employer does not offer coverage that is both affordable and provides minimum value, and as long as the individual is not claimed as a dependent by another taxpayer. So although we expect the cost of coverage to be more expensive in the exchanges, at least relative to today, many individuals will be able to have that coverage subsidized. Again, anybody making up to 400% of the federal poverty limit. So the subsidy, as you get closer to 400% of the federal poverty limit, the subsidy is less. If you're closer to that 100% limit, then the subsidy is greater. As an example, if an employee earning 150% of the federal poverty limit, and by the way, that would be around $17,000 for a single or $35,000 for a family of four, and that's going to equate to anywhere between $11 and $22 per hour. So a person earning 150% of the federal poverty limit is going to qualify for a subsidy. They will be able to enroll in a silver level plan, and the subsidy for somebody at 150% of the poverty limit is around 4% of their income. So again, looking at an individual making $17,000 a year, that would equate to around $57 per month for a single. Okay, so that's what it would cost them for silver level coverage on the exchange, but they'll also qualify for additional benefits that effectively will buy up that silver level plan, which is effectively a 70% plan. The subsidy will allow them to buy the plan up to a plan that's equivalent to 94%. So we throw that out there just as you think about strategy. There may be a scenario where it makes sense, or you might have employees who are able to buy coverage at a reduced rate than what you're charging, and they may even be able to get a more enhanced benefit than what they're offering. So just wanted to throw that out by way of strategy considerations. Any questions? Anything else you guys want me to hit there?
No, I don't think so. I think we're okay there from that standpoint. So why don't I jump into some of the strategic considerations? But again, before I do so, I'm going to try and field some of the questions that have popped up so that we can make sure there's clarity around things. You know, as you're determining whether or not the player pay mandate even applies to you as an employer, you're going to do so based on that 50 or more full-time and full-time equivalent standard that's measured. So as you look at that 50 or more full-time and full-time equivalent standard, that also means that you have to look at commonly held businesses with rules of aggregation. So even though I might have a business that's 20 miles or 200 or 500 miles apart, if there's common ownership in that and it meets those rules of aggregation, those two entities are combined for purposes of determining whether or not player pay applies. So that's one thing to look at. There's been a couple of questions around penalties and how they apply. The penalties that Scott referred to, either the $2,000 no offer penalty, that's going to be amortized over a 12-month period. So it's based on the number of people, per month. It accumulates to $2,000 over a 12-month period. Likewise, the $3,000 penalty applies the same way. And then there's always some confusion around when we're trying to determine large employer or small employer, whether you use that 130-hour measure or 120-hour measure. Keep in mind, for determining large employer status, the only time the 120 hours comes into play is when you're using it to determine how many full-time equivalent employees you have. An example would be if I had a part-time staff that over the course of a year worked an aggregate of 1,000 hours for all part-timers. I would divide the 1,000 by 120. I would get a dividend of 8.33. You'd add 8.33 to your full-time staff, and if that number plus your full-time is 50 or more, you're in the pay-or-play mandate. So that's where the 120 comes. It's only used for determination of the full-time equivalent. The 30 hours per week or 130 hours per month, that's used for determination of who qualifies as a full-time person. So don't get the two mixed up. They are confusing from time to time. And then as far as we've had some questions regarding the exchanges and whether the SHOP programs are going to be available. They were intended to be rolled out January 1, 2014. The federal government has put kind of a delay on that and said if the state or a region can roll it out, that's certainly permissive, but it's not going to be causing any problem if they're not ready to roll out the SHOP programs to the smaller groups, 50 or less than 50 employees.
Yeah, and the exchanges that are going to be the shops, the exchanges that are going to be run by the federal government, where initially the whole value proposition there was that employers would have choice or employees would have choice amongst various carriers at various levels. And in 2014, the exchanges that are run by the federal government, we basically will not see any choice there. An employer will just simply pick a single plan. And the whole idea of an employee being able to pick a plan that better meets their needs, that functionality won't be available likely until 2015 at the earliest.
And one other comment regarding the SHOP programs. They're only available to small employers. So you have to be less than 50 lives. And by definition, if you're a small employer, you will not be subject to the player pay penalties. So there was a question out there relative to, if the shops aren't ready, do I still have to pay a penalty if I don't meet the compliance requirements? And the two issues are really mutually exclusive. The SHOP can only be used for employers that are small. Employers that are small don't have penalties. Those that are determined to be large cannot be purchasing through the SHOP, and those groups do have penalties. So hopefully that adds a little clarity. And we deal with this every day, so we probably have top-of-the-mind awareness, but the questions are good, so keep them coming in. And we'll try and roll through the rest of today's presentation in that regard. So some of the strategic considerations that we're going to talk about today, we've listed on this slide, and we just wanted to kind of frame things in a general standpoint. So some of the things are, what if I currently have a plan that's grandfathered? Can I maintain that grandfathered status? And if so, how? We'll talk a little bit about that. We mentioned a little bit about private exchange or the exchanges. We've been talking about exchanges really in the public domain as mandated through healthcare reform. There's a whole separate kind of cottage industry that's been born out of healthcare reform that deals with private exchanges. So that may be a consideration going forward. Self-funding, Jonathan and I talked about it earlier. Self-funding might be an option, and it provides some advantages or potential advantages, either with how you design your plans or what kind of costs you're going to be subjected to because of some of the new taxes. Pay or player pay, how do you avoid the player pay penalties? Certainly one of the strategies that employers are thinking of, right, wrong, or indifferent, is to reduce the number of full-time employees, those working 30 or more hours per week. That may have a detrimental effect on the individuals themselves, but it may be a way to preserve the organization as a whole. So there's some conflicting objectives in that regard. And then clearly minimum plan value and the affordability index of 9.5%. That'll come up as well. So we'll try and cover those quickly as we move through the better part of the second half hour of today's session. So with that, Jonathan, do you want to start off and maybe go into some of those considerations quickly as well?
Yeah, thanks, Ed. We'll first start with the the grandfathered status. And to Ed's point, what happens if you as an employer are maintaining a grandfathered plan into 2014? Well, the first thing that you as an employer need to know is that just because you're grandfathered, you still have some requirements to comply with certain aspects of healthcare reform in 2014, and some of those things include eliminating the annual limit restrictions. We need to eliminate pre-existing condition limitations. We need to eliminate adult children under age 26 exclusion when those children are eligible. So right now, one of the advantages of having a grandfather plan is for children up to the age of 26, grandfathered plans can exclude those children should they have coverage elsewhere. Beginning in 2014, that exclusion no longer applies. Also, the waiting period needs to comply with the 90-day maximum. So really, when you look through the things that grandfathered plans need to comply with in 2014, you may need to ask yourself, what's the real advantage of maintaining a grandfathered plan in 2014? Our argument would be that maybe the value's been pretty much diminished, if not fully diminished. Obviously, you're always it's your prerogative if you want to maintain that grandfathered plan. However, maintaining that grandfathered plan may become increasingly more difficult with respect to not changing plan design features, and the value in not doing those things is diminished.
Not being able to change contributions too is another.
Right, that would be the other big issue. Yeah, that would be the big issue. We think that the value in maintaining a grandfathered plan going forward is very diminished. So moving on to private exchanges. To Ed's point about the cottage industry kind of popping up around private exchanges, the private exchanges will more or less offer or should offer the same type of benefit structure that the SHOP was meant to offer, in that the exchange will offer a defined contribution approach to healthcare benefits. So instead of offering one PPO plan to all of your employees, employees would be able to purchase a plan via this private exchange with some set amount of contribution provided by the employer. Now, the issues that we're dealing with here is, on the positive side, costs are a little bit more certain. Again, it would be fully insured, so you've got the budgetability of a fully insured premium rate. But we might ask the question: will costs really be less than if you were to direct purchase from a carrier? That remains to be seen. It's real interesting that the whole idea of private exchanges is kind of back to the future, in that this is very reminiscent of the cafeteria style plans that were available when the employer would give flex credits or some amount of money to purchase benefits, and then it was at the choice of the employee. So it's a little bit of back to the future there. And we do have some questions about the long-term viability of the plans in the private exchanges. We're somewhat concerned about the potential of adverse selection, and really what this gets down to is something possibly similar in scope to what happened to HMOs in the late 90s and early 2000s, as there's enrollment differentials. If a small group or somebody participating in the exchange, if those good risks start to select themselves out of the exchange, will it impact the rest of those employers that are in the exchange? So that is a concern that we have about the long-term viability of the private exchanges. So another strategy consideration would be self-funding. And in the past, smaller employers or maybe risk-averse employers have been less willing to consider self-funding simply because it maybe wasn't in line with their corporate objectives or risk management strategy. This self-funding your benefit plan may be a strategy that needs to come back into consideration simply because of the potential cost impact, especially for smaller employers. On the positive side, self-funding will be a way to eliminate the health insurance tax, which is one of the new taxes or fees associated with healthcare reform. The other thing is that self-funding will allow employers to reap any of the benefits of the cost containment features that are added to a plan or any type of wellness strategies that are implemented at the employer. In a community or adjusted community rated basis, some employers are going to be impacted negatively because they won't see the full advantage of implementing a wellness strategy. The cost savings may not be there. On the negative side of self-funding, though, this again gets back into the typical discussion around self-funding. We have the claim fluctuation issue, so we've got a budgeting issue for small employers that may be prohibitive, and then we have the risk transfer issue. If you're a small employer now and you're purchasing HMOs, do you have any way of knowing whether or not you have a high utilizing population, a low utilizing population? It may be very difficult for small employers to make that determination.
I think, though, as we've talked to our partners in the insurance company world, I think they all seem to be of a similar mindset, that being that they expect to see more and more smaller employers consider self-funding, again, in particularly in light of, some of more plan design flexibility and the opportunity to avoid some of the taxes associated with insured plans as we move beyond 2014. So for whatever that's worth, that's kind of what the expectation there is.
Yeah, and the other issue that we've talked about with our colleagues in the market is the potential for states to implement restrictions on stop-loss insurance. And really what that gets to is to say if you were to purchase stop-loss insurance as a self-insured provider of benefits, you can only have a specific attachment point of $50,000 or $70,000. And really what that's meant to do is create a disincentive for employers or smaller employers to go self-insured and purchase a small or a low attachment point of $25,000 or $30,000.
And I think we've gotten a handful of questions from the audience so far in terms of the HIT tax, the health insurance tax, in terms of what the expectation there is. And you guys, what I'm hearing, I think our insurance carrier partners are saying anywhere from 2.5% to 3.5% is kind of ballpark what we're anticipating.
Yeah. So what that really means at the end of the day is, for those employers that choose to adopt a self-insured plan, they can avoid that HIT tax of 2.5% to 3.5%. And obviously that can be pretty significant. Now, the balancing act, as Jonathan and Scott have talked about, is what are the risk transfer levels, and is it still a viable option to, protect the financial integrity of the plan sponsor? So those will all have to get considered in the determination of, do I go self-insured or not?
Yes. Okay, so moving on, another strategy consideration, and this, at least early on in healthcare reform discussions, was the elephant in the room. Will employers eliminate sponsored coverage? And is that a sound strategy? Well, again, whether or not it's a sound strategy is going to differ employer to employer, but eliminating coverage does allow employers to remove the hassle and administration of offering benefits, and the employer can then focus on the core business. There's a cost of providing employer-sponsored coverage that's greater than the penalties. So that's an issue too. Can we reduce our operating expenses by eliminating coverage? A related issue to that is that the penalties aren't deductible. So the tax issue comes into play there. The downside of eliminating employer-sponsored coverage is, what are you going to have to do as an employer to adjust compensation for the fact that you're eliminating benefits, and in order to retain and recruit employees, you may have to make compensation adjustments for the fact you're eliminating coverage.
Right, and I think when we did our last seminar, just to pull some data from there, I don't have the actual number right in front of me, but when we asked the question specifically, and there were over 400 people attending in that seminar or webinar, we asked them specifically if one of their strategies was going to be exiting the employer-sponsored marketplace. I believe the answer was less than 20% of that population. Now, certainly that's not necessarily a scientific poll, but it's probably directionally consistent with what we hear as we're talking with employers. So to your point about eliminating coverage, it doesn't seem to be a prevalent strategy from that standpoint, and the fear tends to be around the whole attraction retention marketplace in general.
So I'm going to get into the next strategic consideration, but before I do that, again, just looking at some of the questions that are coming in, I had mentioned the HIT tax at around 2.5 to 3.5%, and what I meant by that was 2.5 to 3.5% of premium. So all things being equal, you would expect your premium to be 2.5 to 3.5% higher in 2014 as a direct result of the HIT tax than prior to 2014 when it didn't exist. Okay? So thank you for your questions, and keep them coming in. So getting back to the strategic considerations, I kind of feel like the pendulum has swung a little bit. Jonathan talked about employers maybe considering eliminating group-sponsored coverage altogether. And I think when healthcare reform was first born back in March of 2010, there maybe was a knee-jerk reaction by some employers to say, once they found out what the penalty was, where, gosh, a $2,000 penalty sure sounds a lot less than maybe the $8,000 or $9,000 per employee per year that I'm spending today, so I'm just going to exit the marketplace. I think we had that conversation with a lot of folks back then. The pendulum, I think, has swung. And as we start getting into the details of reform and we consider the fact that the penalty is a non-deductible penalty, I think a lot of employers that I'm talking to, their strategy might be more where I'm going to avoid paying a penalty at all costs. So in other words, I'm going to make sure that I offer a plan that's at least a 60% plan. And by the way, I think, virtually every employer that I've talked to over the last 6 months, I don't know that I've seen a plan that has not met that minimum threshold. All plans virtually have been greater than 60%. So I'm going to offer a plan that meets the minimum value, and I'm going to make sure that I make it affordable so that I don't have to pay a penalty on anybody. And certainly, I think that feels really good if you're an employer. I mean, what employer doesn't want to say that I provide quality benefits at an affordable price, right? I think everybody, theoretically, that sounds great. But getting back to the point earlier when we were talking about subsidies, maybe that the pendulum swinging the entire opposite direction, maybe that's not the optimal place for you to be. It probably is prudent to take a look at your population, and let's consider, or you likely should consider, which of your employees would qualify for the subsidy potentially. And if we're able to create a situation where your employees might be able to get a better benefit because of the subsidy at a reduced cost, again, because of the subsidy, relative to the plans that you're offering them, does it make sense maybe to have coverage be unaffordable for some, create kind of a win-win situation? So I think that's what we're throwing out, that concept here with this slide, or something to consider. The next strategy consideration is probably, a 180 from even that, where some employers have been talking about, and this has been getting a lot of press as of late, particularly within certain industry groups, where their strategic consideration is going to be a more concerted effort around reducing the number of full-time employees that they have. Again, healthcare reform does not require that you provide coverage to non-full-time employees, and you're not subject to penalty for not offering coverage to your non-full-time employees. So, that certainly would be a cost-certain position where you just effectively reduce the number of hours that most, if not all, of your employees work, making them all part-time. Therefore, you're not subject to penalty on behalf of anybody.
Yeah, it's interesting when you start talking about that. You could still find yourself in a situation where you're deemed to be a large employer because of the number of part-timers and the number of hours they work in aggregate. But at the end of the day, you might find that you only have a handful of people that qualify at the 30-hour level, and therefore those are the only ones that you have to provide the benefit to.
Right.
So it's one of those things that it can produce interesting results depending upon what your hiring strategy is.
But, as the last two bullets on that slide indicate, if you're going to deploy that strategy, you certainly need to consider the impact that that's going to have on your core business, right? So, will people who are either receiving a benefit today because they're full-time, if you reduce their hours, are they going to be compelled to leave and go someplace else? That type of thing. And also, obviously, consider the impact that could have on morale.
Right.
If they're used to 40 hours a week and now they're getting 25, 27, how viable is that?
And that's before you even address the whole issue of, there's additional hiring costs and maintenance costs of a larger staff when you have more people doing the same amount of work. So lots of factors come into play there.
Yep, and then the last one that we're going to talk about here before we get into a couple case studies and then focus more on questions might be a strategy where, again, you offer a plan that meets minimum value. So again, I mentioned earlier that virtually every plan that I've seen to date, employers are offering benefits significantly more valuable than what the law requires. Again, most plans that I've seen have probably been in that 80 to 85% range. So as an employer, you could still reduce the value of the plans that you offer, and there are cost savings associated with doing that. And you could certainly, make it affordable by simply charging a flat 9.5% of each employee's wages to ensure that it's affordable for every employee. So that strategy, you're going to avoid any potential penalties because you've made it affordable for everybody, and you've maybe offset that cost by making it affordable by reducing the benefits slightly, maybe substantially. But, what's the administrative burden for doing that? Is it feasible? Does your payroll system have the flexibility to calculate contributions as a percentage of of an employee's wages and so forth? So, kind of the con to that strategy. So, again, really all we wanted to do at this point is to throw out a handful of more generic strategy considerations. None of these, as Ed mentioned, are a one-size-fits-all type approach, just more than anything food for thought.
So why don't we go ahead and we've got about 15 minutes or so left. Why don't we go ahead and jump into a couple of these case studies. We've tried to answer some questions. I apologize if your specific question hasn't been answered, but let's get through some of the case studies and maybe we can weave in some more clarity as we go through there.
All right. So the first case study we'll go through is for a small employer. So in this case, we're going to look at a manufacturing company with approximately 45 employees. The average age of the group is 37, and employees at this manufacturing company have a choice of two medical plans. They can choose a $500 single or $1,000 family deductible plan or a $1,000 single, $2,000 family deductible plan. And both options cover the same things. Really, the only difference is what are the deductible and co-pays and things like that. But it's two different flavors of a plan that employees can choose from. And this employer has a renewal date of January 1st, 2014. So what are the things about healthcare reform that this employer is going to need to take into consideration? First, the first question is, this employer is getting very close to that 50 full-time employee or equivalents mark? Are they a large or small employer? Well, in this case, the employer has 45 employees. They don't hire or employ any part-time employees. So for this purposes, this employer is a small employer.
And as a result, does not have to comply with player pay mandates.
Correct.
Nor are they subject to penalties, correct?
Correct. Now, the next thing that the employer is going to have to take into consideration is how is this new pricing, the new pricing requirements for the insurance carriers likely to impact my group? And we saw that this employer has an average age of 37. Well, it's very likely that because this group has a young average age, that they are going to be negatively impacted or disproportionately negatively impacted by the change in the rating methods at the insurance carriers. And that's because they have a younger average age than the entire population in general.
And the impact comes through because of that compression in the rating scale going to a 3-to-1 versus something that might be 10 or 12 to 1 in the current schedule.
Right. So what you're likely to see is that employers with a younger average age are going to be disproportionately negatively impacted, whereas employers with an older average age may actually benefit from that change. And the next thing that we're going to have to look at is the plan design. The plan designs that we're offering right now may or may not fit within the metal tiers. And I say that because the plans in the small market need to be plus or minus 2% of the actuarial value for each metal tier. And we'll show you that in a couple slides. But in the event that the plans that this employer is offering right now don't fit into those nice little buckets, that employer may have to change the plans that are being offered. So that's something to know, and just to make note that issue is something that isn't exclusive to buying on the shop or the exchange or outside of the exchange. That's an issue that's going to impact small employers in general. So what are some of the things that this employer should consider doing to address healthcare reform? Well, the first thing, I might suggest that this employer accelerate their renewal date. Talk with the insurance carrier to potentially move the renewal date from January 1st to December 1st, 2013. This will avoid or at least delay the impact of the pricing change or the rating change at least for another 12 months or 11 months. This employer may also want to consider self-insuring. You may be scratching your head saying 45 employees, there's no way a 45 employee company would consider self-insuring. Well, if at an average age of 37, if this is a tight-knit group and everybody knows that there isn't a high utilization of health care, it may be a reasonable strategy coupled with the proper risk protection with stop loss. It may be something to consider. And then the other thing that this employer may have to consider is choosing new plans that fit within the metal tiers that may require an increase in benefits, a decrease in benefits, or maybe both. Maybe what you do is you take one plan up and one plan down, create more spread in what you're charging employees to contribute, and take that strategy. Now the next page is just a quick reminder of the metal tiers because it's likely to impact many small employers. Just keep in mind that the plans that you're purchasing will need to be plus or minus 2% of the stated actuarial value. So a platinum plan that's listed at 90%, that can actually be 88 to 92%, and that would be a platinum plan. So just keep that in mind. It's something that will probably impact many employers.
So one of the things, I think the reason we bring this whole issue up on this small employer group is a lot of times employers have said, we're a small employer, we're not impacted by player pay, we don't have anything to worry about. Well, I wish I could say that's the truth. The bottom line is there are some things that you're going to have to consider, as Jonathan noted, which could be plan design, it could be plan financing. Those issues definitely can come into play. Pricing, we know that because of the compression in the rate structures, that's likely going to impact the small employer marketplace fairly significantly. So there are some things to get to work on in that regard. Let me ask the polling question here, and it's basically, based on the information presented, the strategy you're most likely to consider would be, are you going to accelerate your renewal because price is your biggest concern? Would you select a lower valued metal tier plan and offer it? Would you handle costs by, going to an earlier renewal date and implementing a lower design? Or really not sure, you haven't considered these? And the answer tends to be that people aren't really sure just yet. Some new things to consider. So why don't we move on to the next one? And Scott, you're going to walk us through a large employer situation.
Yeah, in this particular case study, this example, talking about a multi-state employer with approximately 550 full-time employees. Now, this employer today, they offer a single self-funded medical plan, no options. Every employee has the exact same plan. When we test the plan, it provides an actuarial value of 90%. And when we consider affordability, when we consider what the lowest paid employee earns, we know that the current contributions that this employer is charging, their plan is affordable for all employees. The other fact to consider is when we look at the average cost for medical and pharmacy for this employer, they're spending about $8,000 per employee per year for the level of benefits that I just described. Okay? From a healthcare reform perspective, though, this 550 life employer group, they have about 60 contract employees today. And we didn't get into a lot of detail or any detail on this fact, but from a healthcare reform perspective, we use the common law standard of determining whether or not an individual is an employee. And in this particular case, these contract employees would be considered an employee of the employer. And today, that employer does not offer coverage to that group of people. Okay? If we look at the number of people, the 60 contract employees versus the total of 550, the contract employees represent about 11% of the entire employer group. Okay?
And just a quick comment. Scott mentioned that we use the common law standard for determination of employee. That's actually written right into the regulations under healthcare reform. So that's not our choice. That's a requirement.
Exactly. So from a strategy perspective, a couple things to consider. One, if the employer doesn't do something about those 60 employees, if they don't offer them coverage, that will trigger their no offer penalty because that 60% or that 60 represents 11% of the group, so they have not offered coverage to at least 95% of their people. The no offer penalty is triggered, so it's a $2,000 penalty times all full-time employees minus the first 30. So that penalty to that employer would be just over $1 million. Okay. The other thing they could do is simply offer that same plan design to all 60 employees. That the plan that today averages $8,000 per employee per year. That's an added cost to this employer of almost $500,000, $480,000. Or maybe what we could do is offer the current plan, but charge the employee a significant contribution, maybe even as high as 100%. So at that point, we've offered coverage to everybody, but we've made it unaffordable for 60 people. And in doing so, that would trigger, if we assume that all 60 people qualified and purchased subsidized coverage through the exchange, we're looking at a penalty that the employer would pay of approximately $180,000. Okay? Or maybe a more moderate approach would be to offer that group of 60 people a plan design that's less valuable, maybe one that's a 60% plan. And again, going back to my earlier comment, just charge a flat 9.5% of wages for those groups of people. Okay, so just a couple strategy ideas. We do have a bullet point in here. We'd still want to make sure that anything that we deployed by way of a strategy is compliant to 105H non-discrimination rules, as those do apply to a self-funded employer group.
And actually there was a question that came up earlier with respect to some of these strategies we're talking about, and could that trigger some ERISA issues? Bottom line is very definitely this is one such issue under Internal Revenue Code in terms of non-discrimination requirements for self-insured plans. So recognize that there are competing issues out here. Okay. Last polling question that we may will address, I guess, is again using that information. Would you extend the same benefits and contracts to the to the contract employees? Would you select a lower plan or a lower metal tier plan and offer it to the contract employees? Or again, not sure. And early returns, as we look at them, about half of the people, or actually about 2/3 of the people, are saying really not too sure. Chances are we're throwing out some ideas that are new from that standpoint. Hopefully they address issues that might be contemporary. So.
Hey, just while we have a minute, I saw a couple questions around the same topic, which is the defined contribution approach to offering benefits in the future. Some of the questions that have been asked are regarding HRAs, and I'm assuming that the question really revolves around standalone HRAs. Standalone HRAs, as a means to provide a defined contribution approach, are not allowable beginning in 2014. So the defined contribution approach actually has to be done through an exchange. It can't be done through a standalone HRA where an employer would fund the HRA and then reimburse individual medical premiums. Those are not going to be allowed beginning in 2014.
Okay. So good information in that regard. We're down to probably the last couple of minutes from that standpoint, and I think we actually have one issue. Maybe, Scott, if you want to just point out the salient issues that come out of this fairly quickly, I think that would be helpful.
We had one other case study that we wanted to share with you. You'll see from the slides, which you'll get later, it had to do with a group in the retail industry. And the long and the short of it is, as we consider what this employer is currently offering today, and I don't think it's uncommon in the retail industry world, their contributions today are unaffordable or would be unaffordable for all employees. So it would effectively subject the employer to a penalty on virtually all of its employees because it's unaffordable for all of its employees. And the points that we were going to make here was this employer group was probably faced with a situation where their only alternative is to really bifurcate their population and offer benefits that are affordable to their key employees. And beyond the key employees, they would effectively reduce the number of hours for all other employees, making them non-full-time.
Right. So there's, again, and we've got a polling question that really kind of goes through the same approach, which would be continue the current strategy, accept the risk of a penalty, look at lower valued plans, exit the market, and accept the no offer penalty. And again, not sure. So I know this is very quickly presented. The information seems to be most people are really not sure. It's probably more don't understand all the options here than they're not sure. So as we wrap up things, I guess a couple of comments. Number one, everybody that participated here will have the availability to view the slides and listen to the session again, where you can hear the video along with the slides. We certainly appreciate your participation in today's session. Just a couple of comments from me is, again, I have to go back to the idea that we started with, which is, these are issues that we've come across as we've been working with a lot of employers over the last 6 months as they're trying to get ready for healthcare reform and formulating their strategy for 2014. None of these are meant to be prescriptive as they relate to you specifically. You really need to engage in a discussion. And as I've said many times, this is not the year to start your renewal process 30, 60, 90 days ahead of time, because you can see the complexity of the issues is significant, and there's more than just going through the open enrollment. With that, just a little commercial as we close up. We've got one more scheduled webinar that's scheduled for June 13th. It's really going to talk about some of the issues with respect to exchanges, public and private. So please, we welcome you to join us for that. There is material available at the Plant Moran website that we've produced throughout the last few months, both articles, prior webinar. We did some video vignettes. Avail yourself to those services, and hopefully they'll be helpful. With that, thanks very much, everybody, for attending. Jonathan, Scott, thanks again for your insight.
Thank you.
And we hope to be able to talk in the future at another webinar.